Okay, the second half of transfusion reactions. We're going to talk about TRALI and TACO, transfusion-related acute lung injury and transfusion-associated circulatory overload, along with septic transfusion reactions, transfusion-associated graft-versus-host disease, and why we irradiate blood products. And then finally, the way I think about serious transfusion reactions, and of course there are practice cases instead of quiz questions. So the approach to the practice cases is ask yourself the question, what should I do next? And what other information do I need? And I'll try to present it as realistically as possible in those questions. So it's difficult to find a cat or dog picture that has anything to do with TRALI, and I realize it's a stretch, but it's the best I could do. So what is TRALI? It's currently the #1 cause of transfusion-related death. It's one in usually a few tens of thousands, but keep in mind that just because you have TRALI doesn't mean it's fatal. So only about 5% of TRALIs end up being fatal. And one key thing to keep in mind is TRALI is a clinical diagnosis, right? There's no good lab tests, as we'll see. And TRALI can happen in basically 2 steps. One step is a predisposing recipient condition in the patient that causes their neutrophils to be primed. So the neutrophils are already on edge because of the patient condition, #1. And then #2, in immune TRALI, there are leukocyte antibodies in the donor plasma. So in the transfused product, there are leukocyte antibodies that then target the patient, and then as we'll see in the pathophysiology, leads to lung damage. So that could be the second step in immune TRALI, antibodies. Or in non-immune TRALI, you basically have not antibodies. You have the so-called biologic response modifiers that are elaborated during storage. And this is adequately vague because this is not well understood yet what exactly is causing non-immune TRALI. So we'll spend most of our time on immune TRALI and have a few words about non-immune TRALI. So there was this consensus criteria developed for TRALI, and what they said was an acute onset for acute lung injury, meaning during or within 6 hours of transfusion. And we see hypoxemia, usually O2 sats drop by about drop below 90, so at least 10% on room air. But of course, if they're already starting at a low level, I want to see a 10% decrease from their baseline. Or other clinical evidence of hypoxemia. Bilateral infiltrates on chest x-ray, no evidence of atrial hypertension. What we're trying to rule out basically is that this is not due just to volume overload, right? That this is lung damage as opposed to just lung drowning. And then no pre-existing acute lung injury before transfusion in the ideal textbook case with during or within 6 hours after transfusion. And you've ruled out any other cause of this, right? There's no temporal relationship to an alternative risk factor, again, in the textbook case. And then all that is for TRALI, and then there's possible TRALI, which means there's a clear temporal relationship to an alternative risk factor for acute lung injury. You could hedge, basically. So this is all good, these consensus criteria, but in real life practice, I go beyond this. And what do I mean? Well, think of what's missing from that chart, right? What's missing, #1, is the duration. Like once every couple of years, a resident will call and say, oh my God, my patient's having TRALI. And I'll ask them to describe what happened. And they say, oh, the patient got hypoxemic and was short of breath. And I say, well, how's the patient now? Well, the patient's fine now. I said, okay, what happened? Well, for about 5-10 minutes, the patient had trouble breathing and was hypoxemic, but now they're okay. I suspect that's not TRALI. TRALI is usually not subtle. TRALI is usually, the duration is such that they go into severe acute respiratory distress and stay there for at least a couple days and then go back to normal. As opposed to ARDS, which usually lasts for much longer, several days. So the duration is not there, #1. And #2, the severity, I feel like, is probably missing from those criteria, that most all patients with TRALI require oxygen as therapy in order to get over the hump, and a large majority even require mechanical ventilation, right? So another way to say it is it's very unusual to see just a touch of TRALI. Hypoxemia, sure. Cyanosis is common. Hypotension is often seen. Hypertension is pretty unusual. Sure, nothing stops you from having hypertension for some reason and TRALI. You could have fleas and ticks, sure, but in a classic TRALI, there's more hypotension than hypertension, and a fever is also very common. So this is unofficial, right? But if you read around and if you just live through some of these conundrums, what I've come up with is basically TRALI usually starts within 2 hours of starting the product that was transfused. It's very uncommon to see TRALI just hours and hours after the transfusion is completed. It's possible, but it's unusual. And it usually lasts a couple days. Essentially, all patients require oxygen, most require mechanical ventilation, and a touch of TRALI is very rare. These are just kind of heuristics, little rules of thumb that have helped me. And which blood products cause TRALI? Well, if you look at per components, the risk of fatality from TRALI, we see that plasma is number one, single donor platelets or apheresis platelets is number two, and then we have cryo, pooled platelets or random donor platelets, and red cells. So you can certainly get it from red cells. There's a little bit of plasma in there, right? But plasma is the product, FFP and such, those are the main culprits. And as we alluded to before, in addition to that predisposing factor, the predisposing condition in the patient that is usually present and gets their neutrophils on edge, as we'll see in a nice picture, you could have immune TRALI that includes antibodies, or non-immune TRALI that probably includes some kind of biologic response modifiers like lipids. And which antibodies are we talking about? So the most common type is the HLA class 2. So HLA class 2 is the most common, along with class 1 being there to some degree, and then the combination of HLA 1 and 2 being there. So broadly speaking, the most common specificity of these antibodies in immune TRALI is HLA antibodies. But HNA, right, human neutrophil antibodies, human neutrophilic antibodies are also a significant culprit, particularly this HNA3A. So HNA3A is particularly deadly and particularly potent. It seems to be overrepresented in fatal TRALIs and overrepresented in TRALIs due to a red cell transfusion. So a red cell has a relatively small amount of plasma, but just a little bit of HNA3A goes a long way. And who has HLA antibodies? Well, among the donor population, which is generally a healthy population, pregnancy is the most common reason you'll see for HLA antibodies in a blood donor. And if you look at how many times have you been pregnant, along with the incidence of HLA antibodies, the more pregnancies, the higher the incidence of HLA alloimmunization. It can go from a handful of percent, which is probably, frankly, false positives from the HLA antibody testing, which is very good but imperfect, up to the 50s and even 60s, the more pregnancies in the history. So, as I mentioned before, what labs can you do for TRALI? I said it another way, that TRALI is a clinical diagnosis. It's not a laboratory diagnosis. So why is that? Well, the main concept to remember is that there are no sensitive or specific lab tests for TRALI. It's kind of similar to the story for our ITP. There's currently no good tests that are either sensitive or specific. Or to say it more concretely, first of all, TRALI can be non-immune, right? So just because you don't find antibodies to a cognate antigen, this may not be immune TRALI at all. It might be non-immune TRALI. Roughly about 15% of TRALIs are non-immune. That's one issue. The other issue is Just because you have a donor antibody and a cognate recipient antigen, that by itself only very rarely leads to TRALI. So it's necessary for immune TRALI, but it's not sufficient for immune TRALI. Remember, there's that recipient condition that needs to be present in most cases to prime patient neutrophils and put them on the edge. So donor testing can be used to defer donors, right? So another way to say this is after the fact. After you've diagnosed TRALI, then what we can do is, in some cases, especially if there are many donors that donated many products, so we're not quite sure which specific unit or which specific product caused the TRALI, in those cases, instead of just saying, okay, you 15 donors are permanently deferred, in some cases we'll do HLA antibody testing in donors after the fact. And then a few words about non-immune TRALI. This is not terribly well understood, so it's not like it's easy to ask questions about this, but these lysophosphatidylcholines, try spelling that, or lyso-PCs for short, they accumulate during storage, they prime neutrophils, and in animal models, lipopolysaccharides that you would see in a condition that would prime neutrophils, something similar to sepsis or at least bacteremia. So these LPSs in an animal combined with these lyso-PCs have led to acute lung injury in animal models, but the incidence is unknown and there's really no clinical tests. This is in the kind of the research phase. This is just for curiosity, FYI. Then I would remember this picture as the best description of what exactly happens in TRALI, the pathophysiology of TRALI. So I mentioned before, there's a patient clinical condition, usually something like sepsis, bacteremia, trauma, post-surgery, something that activates, primes the neutrophils so that they adhere and are sequestered on the pulmonary capillary beds, right? So that's step one. Patient condition causes priming of neutrophils. Step two is, in the case of immune TRALI, there are antibodies in the transfused product that then activates these already primed neutrophils. In non-immune TRALI, there's some sort of bad humor, some sort of substance that would do this. The relatively same process. Then, why is this bad? You have these activated neutrophils. These are bad because they release their cytotoxic microbicidal arsenal, and that can lead to pulmonary endothelial damage, right? So, in other words, these neutrophils release their reactive oxygen species because they think, because of this stimulus and this previous priming, that they need to go into action, but they don't. And then just by bad luck, by circumstance, this release of ROS damages the pulmonary endothelium. Why is that bad? Now you have leakage, right? You have leakage from the capillaries in the lung into the air spaces in the lung, and that's what causes the respiratory distress that is associated with TRALI. So, long story short, neutrophil priming from a patient condition in most cases, HLA or HNA antibodies causing the step two, or if it's non-immune TRALI, some biologic response modifiers that further stimulate these adherent and sequestered neutrophils, and then that causes the reactive oxygen species to be released by these little lightning bolts, like Thor, and then you have pulmonary endothelial damage and then leakage of fluid into the lungs, causes TRALI. So this is different from cardiogenic pulmonary edema, which is just backflow of fluid. The lungs basically drown through indirect flooding as opposed to direct damage that we see here in TRALI. And then a longer list of predisposing conditions that could prime neutrophils. It could be direct pulmonary injury like aspirations, pneumonia, toxic inhalation, like say a welder inhales some metallic dust, some zinc dust, for example. Lung contusion, say in a boxer, or near drowning. Indirect pulmonary injury, as we mentioned before, probably the most common one is severe sepsis. That could prime your neutrophils. Shock, trauma, burn injuries, acute pancreatitis, bypass, and many drugs can do this, especially overdose. So strategies to reduce TRALI risk. So there's been a big movement last, say, 10, 15 years to go to male donors, especially for plasma. And then if you use female donors for plasma, there's usually some kind of clause in the standards that say, well, number one, you have to check their pregnancy status. You have to ask about that. And then see, among the donors that have been pregnant, do they have HLA antibodies or not? So the most recent AAB standards say that plasma and whole blood, but let's just focus on plasma. Plasma for allogeneic transfusion shall be for males or females who have not been pregnant, so that's the history question, or females who have been tested since their most recent pregnancy and results interpreted as negative for HLA antibodies. Now we're going to talk about taco. And of course, this is not real. This is probably Photoshop, because a real cat would, of course, be eating the taco, yes. So I don't have a lot to say about taco, but the main thing we should mention is how do we distinguish it from TRALI, right? We distinguish taco from TRALI. The first thing I look at, if you call me and say the patient got a transfusion, they have dyspnea, maybe they have hypoxemia, maybe they don't, the first thing I want to ask about is what's their blood pressure doing, right? In TRALI, more often than not, you see hypotension, right? You see a decrease in blood pressure. And taco, nearly always, you will see a significant increase in blood pressure, which makes sense, right? It's volume overload. It's a version of volume overload. Will they have a long duration? 1 to 2 days of respiratory distress in TRALI? Yes. And taco, no. Usually, you just give them some diuretics and they get over this pretty quickly. And then as a side note, the duration also helps me to distinguish TRALI from ARDS. It's one of the few ways I know how to do it, which is ARDS just lasts a lot longer. TRALI is usually a couple days. ARDS is usually much longer. Hypoxemia. In TRALI, we almost always see hypoxemia. In taco, often we'll see hypoxemia, sometimes not. So it's not like the presence of hypoxemia is specific for one of these, but if I don't see it, I'm less worried about TRALI, right? If I don't see hypoxemia, I'm less worried about TRALI. Chest x-ray, that does not help. They basically look the same. You see the whiteout, you see bilateral pulmonary infiltrates in both TRALI and taco. That doesn't help. You can do a BNP, a brain natriuretic peptide, and in taco, it would be elevated post-transfusion compared to pre-transfusion. You wouldn't see that in TRALI necessarily. Should you give oxygen? This is not so much a diagnosis, but a treatment. Yes, in both TRALI and taco, you should give oxygen. And should you give a diuretic? Yes, in taco, right? If you see a significant blood pressure increase, then yes, you should give a diuretic to a patient with taco because that's what they need, right? They need to get rid of this fluid. But no, you should not do it for a TRALI. There's no reason to give a diuretic. Their volume status is okay. It's the lungs that are damaged. So we talked about the treatment of taco, which is diuretics. But how can we prevent taco? Well, number one, minimize transfusions. Don't do it willy-nilly. Only do it if it's truly indicated. You could give it a lower rate, and you could pre-medicate with diuretics. Then I want to say one word about transfusion-associated dyspnea, or TAD, as I call it. This is acute respiratory distress during transfusion or within 24 hours after transfusion, and it doesn't fit the criteria for TRALI or taco. So this is kind of a wastebasket term. When I do this, like Patrice O'Neill, when you see respiratory distress, you think it's due to transfusion and the imputability, but you can't call it TRALI and you can't call it taco. Instead of just calling it nothing, now we have a term in the CDC transfusion reaction guidelines, transfusion-associated dyspnea. We could stamp TAD on the report. And then now we're going to talk about bugs. This is septic transfusion reactions. Septic transfusion reactions. So when should we suspect this, right? Well, I think about it when the temperature gets pretty high in patients who can mount a fever, and it's usually accompanied with something like either hypotension, shock, nausea, or vomiting, among the most common manifestations, or rigors. Now we're getting less specific. Tachycardia, defined as a rise of at least 40 beats per minute, or dyspnea. And then, of course, you ruled out things like TRALI and TACO. And there's a nice AABB bulletin that helps guide you through when should I suspect a septic transfusion reaction due to bacterial contamination, when should I do a blood culture on the patient and the unit. So when you suspect a septic transfusion reaction, we need to culture the patient and the unit, assuming there's anything left in the unit, and they may need supportive care, especially with their blood pressure, and after drawing the cultures, give them broad spectrum antibiotics. And I tend to be wary of frivolous blood cultures, right? I don't want to do it if it's not warranted. And how I think about it is fever by itself is usually not enough to warrant a culture. When I say fever, I just mean a 1 degree increase. Sure, you could argue a really high increase by itself could warrant it. Okay, that's kind of a moderate argument. But I usually look for things that we talked about. You know what I mean? I usually look for, do they have hypotension, significant hypotension? Do they have nausea, vomiting, rigors, tachycardia, dyspnea? I like to see one of these to kind of push me into the moderate argument for getting a culture into the really good argument. And so why am I concerned about this? Well, the main risk here is a false positive culture, right? If you have a blood culture that you really didn't need to draw, and then it grows a contaminant in the culturing system, it's not really from the unit, it's not really from the patient, well then now you're kind of stuck with this positive result and you don't know what to do with it. Like, should you give the patient antibiotics to treat this lab phenomenon even though there's nothing growing in the patient, or should you not? This kind of thing. So another way to say it is that most cultures that are positive, when you have just a fever, you know, say a moderate fever and nothing else, most positives end up being false positives due to a contaminant in the culturing system. So it's a case of true, and unrelated. That, you know, why do this to yourself? Why make it difficult when you're writing the report? Have a decently high standard for drawing a culture instead of just, they had a fever, 1 degree increase, you know, draw a culture. Seems excessive to me, but that's just my point of view. So what kinds of bugs, right? What kinds of bugs can cause septic transfusion reactions? Well, in red cells, we need something that's able to survive in the refrigerator. Psychrophilic, they call it. I'm no microbiologist, but I like that word. Psychrophilic means they like the cold, they can handle the cold. And the number one most common bug seen in septic transfusion reactions in red cells is Yersinia enterocolitica. Other bugs can certainly cause it, but Yersinia is tops. And the main thing to keep in mind is, if you remember this causes kind of an acute gastroenteritis picture, then you could understand how this would not be, in most cases, this would not be a subtle change in the patient, right? It would be just like infusing them with endotoxin. It's usually going to be pretty dramatic. It's usually not going to be just a tiny temperature increase and that's it. For platelet bugs, bugs that can grow at room temp and only during a 5-day interval, because that's the shelf life of platelets, the way I think about it is whatever is there has to be there in large quantities. So I think about it as it's got to be something on the skin, right? So coag-negative staph is the most common one, but lots of others have been implicated. So staph epidermidis is the most common, some gram-positives in platelets as opposed to a lot of gram-negatives and cold-loving bugs in the red cells. So this is describing bugs that grow in platelets that have been implicated in septic transfusion reactions, right? But if you just look at all contaminants. So platelets that don't end up causing transfusion reactions, if you just culture 1,000 units of platelets, what's the most common bug that you find? What's the most common bacteria isolated is the zit bug, or the pimple bug, Propionibacterium acnes. So that's the most common bug. So depending on the question you get pimped with, right? If somebody pimps you with what's the most common bug overall isolated from platelets during storage, it's P. acnes, the zit bug. If, however, they ask what's the most common bug implicated in septic transfusion reactions from a platelet transfusion, that's coag-negative staph, most commonly staph epidermidis. Okay, so two slightly different questions. And then transfusion-associated graft-versus-host disease. You might ask, why are we talking about this in transfusion reactions? It's not really a reaction as such, meaning it doesn't happen immediately during or right after the transfusion, but it is a bad side effect of transfusion, and we got to talk about it somewhere. So this is different from the graft-versus-host disease of a solid organ transplant or a bone marrow transplant. And how is it different? Well, transfusion-associated GVHD is uniformly fatal, and it must be prevented. The reason it's uniformly fatal is because usually the bone marrow is toast in transfusion-associated GVHD. So the patient has no ability to make neutrophils or any other blood cells, so they end up being a sitting duck and dying from it. So we have to prevent. Since there's no good treatments for this, we need to prevent it. And how do we do that? We irradiate. We irradiate the red cells and the platelets. So you don't need to irradiate plasma for many reasons. Number one, the freeze-thaw process among frozen plasmas generally would kill any trace amounts of white cells. And more importantly, there just aren't any white cells in plasma. During the collection process, there's just no cells of any description, and at least no viable cells in plasma. And we want to radiate the red cells and platelets that we give to severely immunocompromised patients, severely immunosuppressed, iatrogenically suppressed patients as the most common patient population, and also from relatives or HLA similar donors. We'll see why that is in a minute. What I mean by relatives is like your first degree relatives that are donating directly to you, or HLA similar donors like an HLA matched platelets, or in a country that has a lot of HLA similarity. That's another population, and also for intrauterine transfusions and neonates. So the rationale here is that they're kind of in this immunocompromised population. Their immune system is not ready for prime time yet. That's one argument. Another argument for neonates is that it takes time to recognize an immunodeficiency. So even if the patient's old enough to have a relatively mature immune system, in rare cases where there is an immunodeficiency, that would not manifest really early in life because of passive immunity from the mom, right? So sometimes some hospitals go up to a year, neonates get irradiated red cells and platelets. And what happens in TA-GVHD, in addition to what you would normally see in other types of GVHD like fever and rash, liver and GI manifestations, you also see pancytopenia in TA-GVHD as opposed to a bone marrow transplant GVHD, because the graft in a BMT is the bone marrow. So in the patient, the bone marrow is one of the few organ systems that is functioning to some degree because it's from the donor. And that's the donor graft that's attacking the rest of the tissues. And this can lead to sepsis because you have no neutrophils in TA-GVHD, and multi-organ failure and death. So how does this happen? Well, in the normal patient, not the immunocompromised patient, but in an immunocompetent patient, you have in the transfused product all these little Pac-Man, these little T cells that can recognize your antigens as foreign, but if you have enough of your own soldiers, Pac-Man, then they can kill these neutrophils, kill these T cells and stop these T cells from proliferating. So basically your army is bigger right? Your army will win that battle. In an immunosuppressed patient, you still have in the donor unit, you still have these little Pac-Man T cells that can recognize your antigens as foreign, and assuming they have not been irradiated, these T cells can proliferate. And so these T cells can proliferate, and then their army has a larger size than your army. So their army is bigger than your army because of the proliferation. And so what we'll do is in an immunosuppressed patient, we will irradiate the red cells and platelets so that these T cells cannot proliferate. So that's in the setting of an immunosuppressed patient, immunocompromised patient. But I alluded to directed donation, first degree relatives, HLA similarity, right? What's going on there? We want to irradiate those blood products in those situations because look at this HLA locus and this HLA locus, right? So these are the same loci, and assume that for all the other loci, the donor and the recipient are identical, right? But at this locus, the donor is homozygous, right? The donor is homozygous for an antigen, and the recipient is heterozygous for that antigen. So said another way, the recipient has an antigen that the donor does not, but the donor does not have an antigen that the recipient does not. So how this turns out is when the recipient T cells look at the donor T cells, the recipient sees nothing foreign, right? If all these other loci are the same and the donor is homozygous at the same locus, the recipient is heterozygous, let's say the donor is A6 homozygous and the recipient has A6 and A7. Then the recipient will see A6 and go, yeah, okay, no problem, I'm A6 yourself. But that is in fact not the case. And we could run into trouble because the donor sees the recipient and sees non-self. The donor, remember, has A6 and looks at the recipient and sees the A7. So sees non-self. And then again, assuming these T cells have not been irradiated, these T cells will proliferate, and then you'll run into transfusion-associated graft-versus-host disease, even if the recipient has a healthy immune system. Okay, before we do the practice cases, I just want to take you through how I think about, quote, serious transfusion reactions. And what I do is I just think through, when you call me, I think through, okay, can I rule out these 5 types of serious transfusion reactions? It doesn't mean all our work is done, but I like to think through what are the most severe types of reactions, and if it's not one of those, then sure, we have to be diligent, we have more work to do, but we are not going to overlook something potentially deadly and potentially something that we need to urgently act upon, right? So I look at the clinical manifestations and the reaction type and what we should do about it. And also on the top, we look at the timing. This is rough, right? Some things that are on the left that we call immediately or rapidly sometimes takes a little bit of time. Things that often happen later can happen right away. It's rough. So let's go through the first one. If we see fever and chills, back pain, dark red urine, diffuse bleeding and oozing, right? Often in concert with decreased blood pressure, that makes me worried that we have an acute hemolytic transfusion reaction, and that can be due to an ABO incompatible transfusion. It's not the only way you can have brisk hemolysis, but that is one way we need to make sure we don't miss. And so if we suspect that, then we need to bolus saline and diuretics and call for help, right? And in every one of these circumstances, always make sure that the unit is stopped, right? They've stopped the unit, not slowed it down, but stopped it. So that's acute hemolytic. And then on the second one, if we see usually no fever and almost always with severe hypotension and shock, often with bronchospasm and rigors, and very often no transfusion history before this. It's not a requirement, but it's commonly the combination that is most commonly an anaphylactic transfusion reaction. I say that you don't always have to have a transfusion history, or you don't always have to have an absence of a transfusion history, because you could have an anaphylactic transfusion reaction just randomly, right? It's not always due to IgA deficiency. But if it is due to IgA deficiency, it's usually when that patient encounters IgA for the first time, right? So if they're having an anaphylactic transfusion reaction, what do they need right away? Epinephrine. They need epinephrine ASAP and any supportive care. And if they need red cells or platelets soon, then we need to wash the red cells or platelets. And of course, always ask for help. Call the fellow or faculty. If you see a high fever, hypotension and shock, a picture that looks like DIC, no overt signs of hemolysis, and in many cases, they were previously transfused okay. So I'm basically ruling out an IgA deficiency. And then one of those kinds of manifestations we saw before in that list under septic transfusion reactions, then I'm concerned about septic transfusion reaction due to bacterial contamination. So they need supportive care, and we need to draw a culture from the unit and the patient and give them broad spectrum antibiotics. If on the fourth one, if we see shortness of breath, hypoxemia that's unexplained, bilateral pulmonary edema, unresponsive to diuretics. Again, you don't have to give diuretics to confirm this, but I'm just saying if someone gave diuretics and they're not responding, and then you see bilateral pulmonary edema, and this is a severe respiratory distress, usually they're ventilated the vast majority of the time, then I'm worried about TRALI, right? I'm worried about TRALI, and they need oxygen, ventilate if unstable, and of course ask for help. And then the last one, if you see an increased pulse and definitely an increased blood pressure, along with some cyanosis, some shortness of breath, there may or may not be hypoxemia. The absence of hypoxemia helps in that it points more to TACO than TRALI. If you see hypoxemia, it doesn't help me distinguish. Then I'm worried about TACO, right? If I see, especially in increased blood pressure, increased pulse, that's painting the picture that they're volume overloaded. So I'm worried about TACO. And in addition to sitting the patient up, the orthostatics and oxygen, diuretics are what the patient needs right away to get rid of this fluid. And of course, call the fellow or staff for help. So when you're talking to me about a transfusion reaction, and I'm gonna ask questions, if you don't tell me already, I'm gonna ask for enough information to basically rule out all 5 of these, right? The first one can be rule out if, number 1, the blood bank workup is negative. Number 2, if you don't see any signs or symptoms of hemolysis, and that basically will rule out an acute hemolytic transfusion reaction. Anaphylactic, if their blood pressure is stable, if they're not going into shock, I'm basically okay with that. Septic, if I don't see the picture of sepsis, severe hypotension, nausea, vomiting, that sort of thing, really high fever, rigors, then I'm not worried about that. TRALI, if they're breathing okay and their O2 sats are okay, I'm good with both TRALI and TACO. And I'm further reassured there's no TACO if they're, in addition to their breathing status being okay and their O2 sats being okay, if their blood pressure is okay, then I'm further reassured it's not TACO. So who is awesome? You're awesome. So that's all I have for transfusion reactions number 2, and go through the cases and ask yourself, what other information would I want to know in real life, and what's my working diagnosis? What's the differential diagnosis, and how can I rule in or rule out what I'm thinking? All right, thank you.